during pregnancy. There are two types of diabetes, pregestational diabetes and gestational diabetes. Pregestational diabetes. It means diabetes is present before pregnancy. Blood sugar will be raised from the day one of the pregnancy. Hyperglycemia is phytotoxic, that is, it causes congenital malformation and it does not resolve after delivery. Now, how will you diagnose? So, when the fasting blood sugar is more than 126, RBS more than 200, 2-hour postprandial is more than 200, and HbA1c is more than 6.5. That is, we consider it as a pre-gestational diabetes. Before pregnancy, day 1 से blood sugar raise होगा, phytotoxic है, इसीलिए congenital malformation भी करेगा. Now comes the gestational diabetes. So, gestational diabetes is when the non-diabetic pregnant female get diabetes. That is during 24 to 28 week, and it is mainly due to insulin resistance because of the increase in HPL hormone. There is no congenital malformation, and it will resolve after diabetes. Whereas the pre-gestational was not resolving after diabetes after pregnancy, but it resolved after delivery. Now, there are two subtypes, that is A1, control with diet, and A2 needs insulin or oral drugs. Diagnosis. So, diagnosis is done by DIPSI, that is DIPSI guideline. So, we will do first test when the female come at the very first antenatal visit. We will again repeat the test at 24 to 28 week because there are high chances then female will get gestational diabetes at 24 to 28 week. So, हम पहले एंटीनेटल विजिट पे करेंगे और फिर से टेस्ट रिपीट करेंगे 24 प्लस 28 वीक. There is no fasting needing. हम 75 ग्राम of glucose देंगे in 300 ml of water and the female is supposed to drink it in 5 minutes. Now what will be the result? So first is after 2-hour postprandial, if the level is less than 140 milligram per deciliter, we will consider it as normal. And फिर से हम repeat करेंगे 24 to 28 week में. If it is more than 140, then it is gestational diabetes. And if it more than 200, then we consider it as a pre-gestational diabetes. 140 से कम है तो नॉर्मल है, फिर से रिपीट करो 24 to 28 वीक की. 140 से ज्यादा है तो जेस्टेशनल डायबिटीज है. एंड इफ इट इज मोर देन 200 then it will be pre-gestational diabetes. Now between the two tests we need to have minimum 4 weeks gap. और अगर पेशेंट पहली बार दैट इज द फर्स्ट एंटीनेटल विजिट इज एट 28 वीक और आफ्टर 28 वीक we will only do one test. There is no need of repeating test like I said here that repeat at 24 to 28 weeks. Now congenital malformation in diabetes. Most common system is CVS, then comes CNS. Most common malformation is ventricular septal defect, then comes the neural tube defect, and most specific is caudal regression, then comes the sacral regression. Now CVS anomalies. Most common is VSD, then most specific is PGA, that is transposition of great arteries, and it is non-reversible. Whereas reversible is hypertrophic cardiomyopathy. Antenatal care in diabetic patient. First we will do screening. Second we will do growth scan. Third is antenatal visits. Fourth is urine test, and fifth is fetal monitoring. So first screening. Screening we will do in pregestational diabetes we will do HbA1c. If it is less than 6.5, then there is no risk. If it is more than 6.5, there is high risk of congenital malformation. Now, level 1 is USD and it is early scan. Level 2 scan is target anomaly and it is done at 18 to 20 week. Same we do it for Down syndrome and other congenital malformations. That is chromosomal anomalies. Fetal echo. We will do it at 22 to 24 week. Now, growth scan. Growth scan is done for both GDM as well as pre-gestational diabetes and it is done in two phases. That is at 28 to 30 week and 34 to 36 week. We will check fetal size plus amniotic fluid in it. Antenatal visits. So if the patient is well controlled gestational diabetes mellitus case, we will go for routine visits. If it is not well controlled or if it is complicated case, at trimester 2, we will go for every 2 weeks. That is, patient have to visit us every 2 weeks. And in T3, patient will come to us every weekly. Don't just remember this T1 weekly because it is misprinted over here. Now urine test. So urine test in each trimester we will do urine RM and culture because there are likely chances the patient can be of asymptomatic bacteriuria. Now fetal monitoring. So in high risk pregnancy we will start fetal monitoring at 32 week. That is daily fetal moment count, non-stress test or biophysical test weekly. We will also go for growth scan every 3 weeks and umbilical artery Doppler only if pregnancy induced hypertension is present. Metabolic goals, that is patient is on MNT or insulin, fasting blood sugar should be less than 95, 1 hour PP should be less than 140, 2 hours should be less than 120, HB1C should be less than 6 and average glucose should be less than 100. Now medical nutrition therapy, that is MNT. Goal is carbs 40%, fat 40% and protein should be 20%. Now, insulin. Insulin is a drug of choice in pregnancy, and the route is subcutaneous. Common is a human premix insulin, and vial contains 40 international unit per ml. Maximum syringe use is 14 time, and you can store it at 4 to 8 degrees Celsius. So, drug of choice in pregnancy, route is of the subcutaneous human premix insulin and 40 international unit per ml. Now, management of gestational diabetes mellitus. Step 1, we will start with the that is medical nutrient therapy for 2 weeks. Then we will check 2-hour PP glucose. If the value is less than 120, it means that we can continue MNT only. If the value is more than 120, we will add insulin along with MNT. Now we will how frequently you have to monitor. So in T1 you will do weekly, T3 also you will do weekly. And early phase insulin adjustment is done on every third day. Obstetric management or delivery time. If the diet control case, we will deliver it at 39 week. If in the A2, that is on the insulin or drug, we will deliver it also 39 week. In the pre-gestational uncontrolled diabetes, we will do delivery at 37 week.